So for today, we're going to have 3 talks for today. I will be presenting the first talk on the virtual healing hands for the telemedicine migrant workers. And next we will have Ms. Deepa Swaminathan. She will be presenting the second talk on the ideas to impact collaborative care. And for the final speaker today, we will have Mr. Jay Chong from Railway Pharmacy. He will give a talk on the healthcare access, railways, telepharmacy, and advanced medication dispensing and delivery solutions. Okay. Right. So this is my talk about. So basically, I'm a telemedicine doctor in SATA CommHealth. Okay. Is it my slides? Okay, so yeah, a bit of background on how SATA actually began. It was started after the post-war period. TB was a major threat back then. SATA was set up to tackle this TB issue. So on the 29th of November, the first SATA clinic was officially opened, and that time we were concentrated on providing outpatient diagnosis and treatment for the patients with TB. And in 1955, we started a mobile treatment service to treat those who were unable to afford a trip to the SATA's clinic in town. And over the next few years, we expanded to include cardiology in the service. And in the late 1970s, SATA was actually active in anti-smoking campaigns and educating the public on the link between smoking, heart disease, and cancer. And eventually, in 2009, SATA was renamed to SATA CommHealth. This is our headquarters in Chai Chee. Yeah. Okay, so as a well-established healthcare provider in Singapore, we have a myriad of service available under our umbrella. And one of the latest service is the teleconsultation service used via the SATA app here. So a bit of background on how the SATA telemedicine for migrant workers actually started. It was actually started in 2019 by Ministry of Health, where they developed this telemedicine allocation and reconciliation system, TMARS, which is actually a web-based telemedicine platform, was intended to provide care for the migrant workers who are actually living in the dormitories back then. And then during COVID-19, this was taken over by the Ministry of Manpower to provide the medical care for the migrant workers. So back then they were using this app, Foreign Worker, MOM Care app, and then the doctors were actually using WhatsApp to call the patient. So it was not a lot of privacy back then, so we were using your WhatsApp to call the patient. It was not so organized, but nowadays we are using our own system to call the patients. So for SATA telemedicine for the migrant worker, we launched it on the 1st April 2022. It was a 24-hour service. It started off with me alone and 2 locums and a few support staff. So initially, during the early days, the pickup rate was not too good. There was little exposure. We only saw about 46 patients in 1 month's time. And eventually, after a lot of efforts in promotions, we went to the dormitories to put up multilingual multi-language posters, and we went to teach the migrant workers on how to use the apps, and also we teach them to use the app when they visit the medical center. So eventually our numbers pick up, and as of last month we are seeing around 5,500 patients in a month's time. Okay, so this is just a simplified overview of the workflow for SATA TM service, where migrant worker will download the apps and then they will request for consult via the app, and this will get registered in the doctor's portal, and the doctor can see the details of the migrant worker inside the doctor's portal. And we will call the patient using the portal, where we can also enter the notes, order medicine, and also order MC. So the medicine will be delivered the e-prescription will be sent over to relevant pharmacy, and the medicine will be packed and delivered by the delivery team, and the MC will be sent to the apps, patient's app, and then they can download it and then get the MC from the apps itself. Okay. Yeah. So for our clients, we have migrant workers and also have public patients for our telemedicine service. So this is just the example of the patient's migrant worker app. It was designed to be simple so that they can use it themselves. And this is for the public patients. Okay, so as for now, currently we have 3 resident doctors working and some of the locum doctors helping with us. And the number of doctors working at one time varies depending on the numbers of expected patients. The numbers can varies up to, we can have up to 5 doctors on a busy Monday morning, and for the whole Sunday we only have 1 doctor working, and we provide 24-hour coverage. So this is the doctor's portal. We are using the Clinic Assist software where patients will register and then their name will be reflected here. It's a good portal where we can actually call the patients using this software, and we can enter the case notes and order medicines and also order MC via the same portal, as opposed to last time we have to use our own WhatsApp to call the patients. Now everything's all under one portal, which makes things easier for the doctors. So once the patient was consulted, we will enter the case notes, and then we will order medicines and issue MCs. So for those cases who are not suitable for video consults, we will direct the patients to go to physical clinic, to the migrant worker medical centers. By doing, we will inform our support team, and our support team will liaise with the patient to direct them to the physical clinic. And from the app itself, patient can download the MCs, and then the medicine will be delivered to their doorstep by the pharmacy delivery team. And yeah, one aspect of the telemedicine is the support staff. They are very important in the telemedicine service. They help in contacting patients whenever required. For example, when we use the apps, patients not answering the apps from the portal itself, or sometimes the name or the PIN number might be erroneous, or if we need to update the address, we get our support staff to contact the patients to have all the information rectified. And also the patients will also contact the support staff when they have queries. For example, if they don't know where to find their MCs, or they receive MC with wrong number of days, and the support staff will inform the doctors, and we will assist the patients to rectify the MCs. And the support staff will also assist with IT issue, meds deliveries, update address, all these things. So support is quite important in telemedicine as well. So the common cases that we've seen, not surprisingly, we see a lot of MSK pain because of mostly they are hard labor manual workers, so they complain of body pain, back pain, neck pain. This is quite common with them. We also see a lot of cases with tactile fever, URTI, GE cases, and then a lot of cases like dyspepsia, gastritis, quite common in the migrant worker populations. And we see a lot of cases of skin diseases, especially fungal infections, things like contact dermatitis is quite common. And last but not least, all these patients will just call up and say, I want 1 day MC bro. So yeah, for this kind of group of patients, we have to spend a bit more time to get more information from them, to ask them what's the really main presenting complaints. Okay. So yeah, as opposed to a public telemedicine, Migrant worker telemedicine comes with different sets of challenges themselves. It can be from the patient's perspective, doctor perspective, from the support staff and the pharmacy delivery team. Each comes with unique challenges. So for the patient itself, some of them are not that tech savvy. So we may have a lot of problem with a technological aspect. Some of them don't know how to download the apps. Some of them don't know how to use the online payment system. Some of them don't know how to retrieve the MCs. So for this, we will have our support staff to assist the patients to register, to download, to initiate the payment for the patients. So once they learn after the first try, usually the second time will be easier for them. We have a lot of language barrier, environmental challenge as well. For example, environments is quite unique there because their working environments are usually a bit different than the public populations. They tend to be in a more noisy environment at their workplace and in the dormitories where all men are there, so they're quite noisy. Sometimes during the consult, they can be actually at the side of the road walking. You can't really hear them very well. And this is quite common as well. They are in inappropriate environments. We can see they are requesting for consult when they are in busy packed MRT, busy packed buses. Some of them even driving when doing the consult, and they insist of doing the consult with you when they are in these situations. And yeah, we see a lot of cases. They are actually on the toilet bowl, playing with their phones. When you call them, they are sitting there. So for this group of patients, usually we have to spend more time just to educate them that some kind of ethics that we have to follow for the telemedicine. Not we can do all the time. Yeah. So yeah, language barrier is one of the biggest thing in telemedicine for migrant worker. Most of them comes from India and Bangladesh. In India itself, they have a few hundreds languages, but most of us we do have doctors that can speak Tamil, speak Malay, speak English, speak Chinese, but I think one of the biggest group that we find it difficult to cater is the patients from Burmese, because we don't have any doctors speaking Burmese. So when we encounter this group of patients, when we have issue, we either get some help from they may have some seniors who can speak English, or also what we do is if we can't find someone who can speak English from their friends, we have to refer them to our clinics for physical exam, where we usually have someone who can speak their language in our clinic. Yeah. So some things specific to not more common in the migrant worker population is the connectivity issue, as opposed to the local public population. I have a feeling that maybe using an old device or maybe a cheaper handphone, the connection is not so good actually. We have issue with poor audio or poor video quality with them. They have some broken camera. You can see the lines when they talk to you, and then they may also some of them living this area who have poor internet access. So the connectivity is not so good with them. So for those cases, we try our best to continue with the video consult. But if really bad, we can't see the image, or it's really a truncated videos, then we have to refer them to our clinic for a physical check, where we have a proper physical exam with them. And some of them, sometimes we have issue with the app. The app's not working. Then they will just use their friend's phone and to request for medicine, things like that. But for this case, we have to inform them that they have to use their own apps, and then we have to reject. And then some of them also book by mistake. They just play with the phone and then accidentally book the telemedicine, the teleconsult. So yeah. Okay. So I think another big aspect is expectation from the migrant worker itself. I found it's like a spectrum for expectations. Some of them, they really expect TM as an equivalent to clinic or hospital, where they expect us to treat everything under the sun. So usually this group of people, they really want to work. They want to get their body fixed, and they want to go back to work next day. And the other end of the spectrum is this group of people who just treat us as MC kiosks, where they literally just order, I want 2 day, 1 day, 3 days MC for you. So usually we have to spend more time on this group of people to get more history and educate them on the true purpose of telemedicine. Yeah, and for doctors ourselves, I think one of the biggest challenge is to cope with the sudden surge of patients in the telemedicine. Typically, larger load is expected after public holidays or after long weekends. We can have up to 70 patients registering in 1 hour. This can continue on for 2 to 3 hours, as opposed to a clinic setting where we have a gatekeeper to stop the registration. But for telemedicine, we don't have a gatekeeper, so they will just keep on registering. So it's quite stressful for doctors to cope with the sudden surge of patients. And for our support staff, I think one of the main challenge is patients who are uncontactable. So when we use the app to contact the patients, they don't answer. So we will get some help from our support staff to contact the patients via direct call or WhatsApp call, so that we asking them to answer the call from the apps. So if they provide old number or wrong number, it's quite hard for us to reach them. So this will lead to uncontactable patients. So after a few tries, attempt uncontactable, we just have to close the case. And for the pharmacy, I think the biggest aspect is a wrong delivery address, because patients generally, some of them they don't know where's their address, exact address. Some of them change address frequently, and then it's not updated in the system. So the delivery of medicine is quite a big challenge for the pharmacy team. I think all in all, it's a win-win situation for SATA and for our clients. For our clients, they will get online care from the comfort of their home. They will get, they need to spend time, spend money, more money to travel to the clinic. They get medicines and MCs at their fingertips, and they get affordable care as well. They can just pay $2 for the service, which includes medicines and MC as well. And for SATA, ourselves, we are able to fulfill our motto, which is here to care. So for me, a telemedicine for migrant workers is not only a virtual healing hands, but it's a real healing hands to assist our migrant worker friends. Yeah, so this is a short presentation from me. Any questions from the floor? Anyone? Yeah. No. Yeah. How patient pay for that? Okay, so for our system, they make a prepayment of $2 prior to the consult. So they have to make payment first, where they pay using their debit card or credit card, and then after the payment go through, then only the queue will be created for them. As opposed to some other provider, they can just request first and pay later. But for us, they pay first, then only the queue will create it for them. Mm-hmm.